We often try to keep our personal and professional lives separate, but sometimes these two worlds collide in unexpected ways. That's what happened to me. By day, I'm the CEO of a not-for-profit health plan that provides insurance to almost 3 million people. But when I leave the office and peel off my CEO role, I'm a patient and a family member. I want to share with you my journey as a family member, my journey that led me to join a movement in Massachusetts and beyond that's asking some uncomfortable questions about the healthcare system. What if our approach to end-of-life care has been misguided? What if we're using the wrong language? What can we learn from other big social and public health movements? And what if, and this is the big question, what if we changed our approach to end-of-life care in a way that created the potential to change healthcare itself? Let me tell you how my journey began. 9 years ago, my father, Carl, died at the age of 92. He had been a businessman and a civil rights activist. My father taught me to ask important questions about the world and about what matters most to people. My father's last question came at the end of his life. He had lived with a pacemaker for 3 years, but congestive heart failure meant he was less and less able to do the things that gave him pleasure, tending his garden, reading a good book, playing Cole Porter on the piano. He lost his appetite and he slept for most of the day. Eventually, he didn't have the energy to maintain conversations with those that he loved the most. We had already brought hospice into the home when my father posed his question. "Can we move this along?" he asked. My father's physician said he had an option, turning off his pacemaker. That choice, they told us, is not common, but it's ethically no different than withdrawing other treatment that prolongs life. My father thought about what mattered most to him, and it was the ability to connect with loved ones, and he made his choice. A few days later, the cardiologist came over and wirelessly turned off the pacemaker. His heartbeat began to slow, and slowly he lost consciousness. His grandchildren sang to him, his children said goodbye, and he died peacefully with his wife by his side, just as he wished. Now, my father's path was similar to one taken just a few months earlier by my brother Nick. Nick had worked in radio and TV, but kidney failure stopped his career and imposed decades of illness and disability. With courage and a tough independence, he endured 2 failed kidney transplants and dozens of hospitalizations. But when his physicians told him that he needed another major operation, this time to preserve his leg, and that he would then require possibly a liver transplant, he hesitated to accept any further surgery. Nick thought about what mattered most to him. He wanted to control his own medical destiny. He decided to stop dialysis, knowing it would lead quickly to his death. He entered a residential hospice program and died in less than a week, surrounded by his family. And then just a few years later, my mother, Rosalind, died of cancer at her home, also supported by hospice. She had been an adventurous woman, and even after being diagnosed with lung cancer in the early 80s, she continued to lead an active life. She was also intensely private and fiercely independent. Her apartment was immaculate, everything in its place. The thought of being exposed and out of control in a hospital had terrified her. So when her cancer spread and her health rapidly declined, my mother thought about what mattered most to her, her dignity and her privacy. She received limited palliative radiation, but she wasn't hospitalized, not for a single day. Now, it was devastating to lose my brother and my parents in such quick succession, but I also knew we were fortunate. Each of them were able to articulate what mattered most to them and choose to live as they wanted to the very end. Now, a few weeks after my mother died, I found myself in a conference room in a meeting with Atul Gawande at Ariadne Labs, where I serve on the advisory board. Ariadne is an innovation center in Boston working to improve healthcare at critical moments in people's lives. At the meeting, Atul shared early results from their serious illness care program. This program trains physicians to ask different kinds of questions of their patients. They were not about feeding tubes or do not resuscitate orders or final wishes. Instead, they asked, how much do you know about your prognosis? What are your fears? What gives you strength? What would you be willing to do for the chance of a little more time? These conversations didn't change diagnoses, but they made a difference. Patients felt less depressed and anxious. Their relationships with their clinicians improved. And we know that when people are given the opportunity to truly understand their prognosis and their options, they make different decisions. Some, like my mother, are more likely to opt for hospice rather than hospital. Some choose less aggressive care and may actually live longer. Others might opt, like my brother, against high-risk surgery that only has a small chance of extending life. Ariadne believed that these conversations were crucial, so they worked with clinicians and hospitals to make sure they happened and happened early enough to change the course of care. It's one of the reasons Ariadne's program is called the Serious Illness Care Program, not the End-of-Life Care Program. Now, listening to a tool that day, I heard echoes of my family's experiences, and I realized at that moment that we had the potential to make big changes. So first I brought together my team at Blue Cross. I said, what steps could we do? What steps could we take to change the experience of our own members? Turns out we could do a lot. We made sure that we paid clinicians for these important conversations with patients. We opened up our hospice benefits. We expanded our approach to palliative care. We brought primary care into the home of older adults with serious complex diseases. We incorporated training about advanced directives into our wellness programs, and we helped bring the Ariadne training program to 7 major health systems in the state. But I knew this was much bigger than my company. Luckily in Massachusetts, we're good at tackling big issues. The first public health department, the first health coverage program for kids, and 13 years ago, we achieved near universal coverage by passing a law that became the model for the Affordable Care Act. I saw another chance here for big change, but I knew that first we needed a coalition. So with a tool at Ariadne, Ellen Goodman at the Conversation Project, and Maureen Bincignano at the Institute for Healthcare Improvement, we created the Massachusetts Coalition for Serious Illness Care. The goal of the coalition is simple but ambitious, to ensure that everyone in Massachusetts has a chance to communicate their values and goals and preferences for their care, and that clinicians have the training and support to elicit, document, and honor those wishes. In 3 years, the coalition has become a major force for change. We're energizing and connecting and amplifying great work that's been going on in this field for years. But we're also creating new partnerships. We brought together our medical, nursing, and theology schools to ensure that young physicians, nurses, and divinity students are taught how to have these serious illness conversations. And we're already seeing signs of progress. Last year, when we conducted research, we found that more people in Massachusetts had a better experience at the end of life. That was encouraging. But what we didn't see was a change in the number of people in our state completing an advanced directive. These numbers haven't budged for years, if not decades, around the country. So it made us wonder at the coalition, what is the best way to talk to people about advanced directives? What would motivate people to act? So working with our partners at Cambia in Oregon, our researchers did a nationwide study of more than 2,500 people, the biggest and deepest such analysis that had been done. We asked about experiences with illness and caregiving and the healthcare system, among other issues. We learned that most people believe that advanced directives are just about the very end of life, about ventilators and feeding tubes and do not resuscitate orders. So our researchers, built an online community to probe more deeply into how the public thinks and what might motivate people to act. We tested language that we commonly use in this field to encourage advanced care planning to see if it actually did the job. Language like, advanced care planning is a gift we give our loved ones so they won't be burdened by having to make decisions without guidance. Or advanced care planning will give us peace of mind. Or advanced care planning is just part of wellness, routine like our annual physical. To our surprise, much of this language didn't resonate. Some of the language made people feel defensive, skeptical, judged, even alienated. Loved ones, for example, turned out to be a term to avoid because many people feel they don't have family to rely on. They preferred the phrase, people who matter. Even the term conversations felt scary to some. Many preferred the phrase, good talks. There were 2 concepts, though, that stood out and resonated across all ages and races and healthcare experiences. First was the idea of control, that while we can't control everything, we can control who speaks for us if we cannot. And that's a traditional way to encourage advanced care planning. But the reality is that accidents or unexpected health emergencies, those times you really, really don't see it coming, those are the exceptions, not the rule. Which brings us to the second, less traditional concept that resonated across all the groups. That when we get a serious illness or become frail due to age, and we all will, we should demand that our clinicians ask and understand what's important to us to ensure we get the best care. They should understand what quality of life means to us, and they should help use that information to help us make choices and decisions. This kind of advanced care planning doesn't start with DNRs or ask us to plan our end of life. Instead, it asks questions like, what do you need for a good day? Watching your favorite sport? Time with family or friends? What brings you joy? What matters most to you? There is a truism in this field about end-of-life conversations. It's always too soon until it's too late. Of course it is, because we frame these conversations as a part of dying rather than about how the healthcare system can help us live well. What our research brought home to me is the simple truth that our clinicians should always know what matters most to us, long before the end of life. It shouldn't be about some hypothetical tomorrow, but about getting the best care today. This is a radically different way than the public understands advanced care planning right now. So can we make this dramatic shift? That's a question many other big movements have asked and answered. Take smoking. In my lifetime, cigarettes have been transformed from a glamorized product to a defective one. Drunk driving used to be a fact of life, but Mothers Against Drunk Driving helped make it socially unacceptable. HIV was once treated with terror and bigotry, but activism, including the AIDS Memorial Quilt, helped change that by shifting the focus to the millions of partners and families mourning loved ones. And the National Campaign for Gay Marriage, another first for Massachusetts, changed the language from a debate about rights to a conversation about love and family, and love won. So what can we learn from these movements? Each figured out a new way of talking and thinking about a big problem, and then each movement created systemic change. So are we in such a pivotal moment today? Do we have a chance to change how we think about serious illness and end-of-life care? I think so. Today we're seeing vast changes in how we talk about illness and mortality. We've moved past the ugly rhetoric of death panels. Books like Being Mortal and When Breath Becomes Air have become bestsellers. These aren't books about dying, they're about living, about how we spend our time, the choices we face, and how those equations shift in the face of age or illness. So can we change our thinking? What if, for instance, this conference was not called End Well, but End Well by Living Well? What if our advanced directives reflected not simply our preference for life support, but how we want to live and get the best possible care? And what if we called those current directives? Shouldn't our physicians know how much our independence and dignity matter to us? Shouldn't they know if it matters that we can garden, read, play the piano, or that we never want to spend a single day in the hospital? What would happen if we in this room decided that healthcare aligned with our values is something we should all demand from our healthcare system every single day, rather than only in the face of death? I don't have the answers to all these questions, no one does, but I believe as a CEO and as a family member that we must create a healthcare system that truly listens to patients, that provides care as we all would want it at all stages of life. And I believe if we are able to fix care at the end of life, we actually have the potential to fix healthcare itself. Thank you.